one of the questions I commonly get from people who are interested in my work is, how do you get, what does it mean to actually do policy research? And so that's the general direction. I'll really get to some of the work and try to really at least tell you how I see some of that work. I think many of us in sort of different stages of our career, we have kind of an origin story, a kind of a moments and experiences where we feel a tug, and we feel like there's something that really pulls at us out of something that's beautiful, or that's suffering of somebody else that really draws us towards. And my origin story started in the early 90s when there was a big immigration of Ethiopian Jews to Israel, and it was almost over the course of a couple of years, almost 1 million Ethiopian Jews immigrated to Israel, my mother at the time was in the university, and she became the faculty coordinator for the newly enrolled Ethiopian students in the university, and she would tell us about how really they're not treated nicely by the university. They were it was hard for them to get in. It was hard for them to nobody was paying attention to them. They all found that they don't have the same kind of training and background, of course. And so she took it upon herself to really make it a home for many of them. And I remember coming back from whatever it is I was doing, and there would be like a group of them with my mom around our kind of dinner table, really enjoying and getting to really sort of start really learning and then benefiting what it means to be a student and to grow in that way. So skip a few years forward. That kind of got me thinking about those populations that are really struggling and the help. And skip a few years forward in medical school. Sometimes you have really influential teachers. I had the teacher that was my kind of inspiration was my parasitology teacher. It was Jamie McGuire. I don't know if you know him.
Yeah, I know Jamie.
Oh, Jamie is, I wrote him, and then as I was thinking about putting this together, I wrote him and just checked in with him and just told him he was such a big influence for me. It was one of the things that kind of struck me about learning about parasites is the magnitude of people that are affected, and that struck me as and that it was all concentrated in sub-Saharan Africa, in South America, in some parts of Asia, and the magnitude of 800 million people infected with Ascaris, 500 with Trichuris, Schisto, Strongy. By the way, any people know what this which worm that is? No one has. Nobody. What's that? No, it's one of those. It's one of the ones that are mentioned. That's Strongyloides. At any rate, the kind of the combination of the magnitude of people who are infected and how concentrated it is, kind of the sense of unfairness and the fact that it can change really pretty easily in some ways of thinking. All you have to do is provide some deworming. So I thought at the time, and that really drew me towards. And then, of course, I started looking at things like, wow, where if I want to understand the global burden, where the global burden of disease is. This is back when I was finishing medical school. This is 1997, and you can see that in low-income countries, what portion of this square is red? Maybe 70%. It's all infectious diseases, and it's enteric infections, and it's HIV, and it's neglected tropical diseases, and malaria, and respiratory, and TB. And if you look at the high-income countries, these things barely register. And that disparity was something that was very compelling to me. And so I went into infectious disease, and as Michelle mentioned, I did my fellowship here. And I remember doing the interview and meeting one of the faculty, David Relman, who is a very senior member of the department, and talking to him and saying, one of the things I like about infectious disease is that you can really engage with that at the molecular level, at the cellular level, at the host level, at the person, at the community, at the population, at the policy level. And he said, that's exactly what I said to my interviewer when I was interviewing for an infectious disease fellowship, and I chose to engage with it at the molecular level. And I said, that's wonderful, and I'm going to choose to engage with it at the policy level. And so there's this is the kind of this was part of what drew me to infectious diseases, and combine that with policy. And so I did a policy fellowship, and the Department of Health Policy has has room for folks who are interested in doing this fellowship. And right away, I was I came in still very idealistic and motivated to identify ways of mitigating a lot of the infectious diseases in sub-Saharan Africa. And I would go to South Africa and talk to folks down there and find colleagues and people who are infected, and try to understand what are the barriers to getting HIV under control. And I would come back and really try to put it in a policy prescription. And the way that I started moving into that work is by saying, okay, let's figure out, let's model what you can do and how much you would have to spend for it, and figure out what are the most effective and efficient ways of addressing some of these challenges. And I started with HIV, and I worked with some very dear friends, including David Katzenstein, who actually very sadly passed away from COVID about 2 years ago. And that was my initial foray into the policy world. You put in a policy that you think, a certain strategy, and you can model out the outcome. And I would sit there and I learned how to model, and I would make all these models of disease. You can kind of see exactly like different cellular levels and virus levels, and different strategies for getting people's disease under control, and that was very compelling. And in many ways, I would both get a flavor of what the issues were on the ground, and then I would go and actually try to model that on the computer. And one of the things that was kind of impressive is that you can really see how you can get a disease under control in a computer model. You can really get that. And that was both something that was very enticing. You can really develop a model that will allow you to get the disease under control, but it was also something that got my head scratching and led me to actually move away from some of the modeling work. And here's why. Around that time, maybe the late 2000, maybe 2009, 2010, there was a very influential idea that came into being. And that idea was that if you take everybody with HIV, test them, a whole country, put them all on antiretrovirals. Antiretrovirals, the drugs that control HIV, they control not just they control not just the health of the person and control the HIV for the person, but they also control whether they transmit to somebody else. And you can effectively eliminate transmission of HIV. And people put it in a model, and it looked like it would really eliminate HIV in South Africa. And so then several trials got going about what to do with HIV, and to try to do this kind of universal testing and universal treatment. And it didn't quite have the same effect. And so one of the things that sort of got me scratching my head is that, look, we can do these things in models, but then it's actual people that we're grappling with, and those have, there's a lot of other considerations that one has to really keep in mind. And if you're really interested in the well-being of individuals, you should keep that in mind. I was a part of this model comparison project, and a whole bunch of us were sitting in Stellenbosch and outside of Cape Town, and trying to see, what would we say would happen in South Africa to HIV under different scenarios. And mine is kind of somewhere there, kind of the red line, somewhere in the middle there. But there were ranges, from that, HIV would either go down to, pretty close to, reasonably low levels, or go way up. And there was another thing that made me realize, all these models and assumptions that go into these models, that was not enough to really understand the policy implication. And so that kind of led to, for me, a shift from modeling to a form of understanding. Okay, and at the time, I was very interested in and a lot of the attempts to control HIV. And for those of you, I realize now I'm like totally, aging myself, or declaring my age, that, this is, so former President George W. Bush and Bono. And, I'm sorry if you all, but anyways, every once in a while I need to actually say that. And this, this kind of iconic picture in some ways was a way that the two of them kind of came together over their commitment to doing something for HIV in sub-Saharan Africa, and under, in fact, any day now in the State of the, whatever, did the State of the Union already happen? I no, anyways, the State of the Union exactly 20 years ago now. Was when George W. Bush announced the creation of the President's Emergency Plan for AIDS Relief. And that was really a paradigm-shifting program. It all of a sudden focused a whole lot of resources, new resources for HIV, and really focused on the countries that were extremely high hit. Everything kind of changed for HIV. And I was very interested in trying to understand what this program was doing, because again, it's one thing to say, look, we're gonna we can very effectively provide all this money, and all these medicines are effective at reducing mortality and transmission, but it's another thing for that to actually happen when you throw money at a problem. And so I was very interested in really getting to the bottom of this. And so I spent quite a lot of time evaluating this program, and that's when I kind of learned how hard policy evaluation is, and the whole process of policy evaluation. And one of my early sort of projects on PEPFAR had me really trying to collect some of the very foundational data one would need in order to evaluate the program, and we did a mediocre job. And soon after we published our paper, the Center for Global Development, which is kind of one of these big global health think tanks or global development think tanks, right away they were like, "Don't believe this paper." Now I was totally devastated, and I said, okay, this, you know what? I'm just gonna do more, and I'm gonna keep working, and I'm gonna keep collecting the data, and I'm gonna keep trying to find the answer. And we continued working and published more work on PEPFAR, on HIV development assistance, primarily from the United States. And really, it demonstrated that PEPFAR was very clear. You can really trace the path from, the program in the State of the Union address all the way down to people getting their drugs, to mortality reduction, fewer orphans, and all of that work. That was pretty satisfying, and I got to go and be part of the National Academies of Medicine. At the time it was the Institute of Medicine for PEPFAR, and we got to go to stand in front of Congress and talk about what that kind of funding was doing. But it was really there was a lot of kind of doggedness that was involved in that. The next thing, PEPFAR was also, it was not always very rosy. That was the other thing that was for me enjoyable in this kind of policy research, is that not everything works, right? And sometimes part of the honesty of being in a research institution is that you get to sometimes just say, like, hey, look, this kind of stuff that you wanted, and you spent a lot of money, many millions of dollars that PEPFAR had spent on abstinence and on fidelity kind of programs, didn't make much of a difference in terms of teen pregnancies, in terms of number of sexual partners. So that this push for abstinence was really, didn't seem to have made much of a difference. And that's another thing that it takes kind of a lot of doggedness to kind of stay with the question. But the work itself can have these rewards. There's a certain art to policy, to doing the kind of policy work, and sometimes I like the analogy of a clock that has kind of the seconds clock and the minutes clock and the hours clock. And if you think of how the actual political world works, they're running, they're constantly changing, right? It's insane. If you try to follow the news, it's just like it keeps changing. There's just, and then there are some things that are working at a glacial pace. Just like if you look at what's happening in terms of foundational physics or something, that's just moving at its own kind of slow pace. And then there are some things that are kind of in the middle, and these arms, they don't overlap. They don't always overlap, but a few times they do, and every once in a while they do. And it's hard to really sort of plan for. You don't know exactly when things are going to happen. But a lot of the work itself is almost like thinking about the issues, and recognizing that at some point these issues are going to they're going to come into sharp view, and in some ways you can also bring them into sharp view, and this is the way that the example that happened to me in my own career that Michelle mentioned briefly was the work on the Mexico City policy, also known as the global gag rule. And that policy essentially says that every time it's a flashpoint in terms of the politics. So every time there's a new party in the White House, they right away, within the first week, they switch the policy on and off. And so the policy effectively says, when it's on, it says, look, the U.S. is not going to fund anyone that supports abortion. Okay, if you say abortion is a legitimate form of family planning, you're done. You're done with any support from the United States. And it turns out that, of course, the kind of organizations that will talk about abortions and will provide abortion care, they're also family planning organizations. And so when you cut off funding for these kinds of organizations, you cut off their money for providing contraceptive pills and condoms and other family planning services. And so you have unintended pregnancies, undesired pregnancies, and you end up with more abortions. And that's what we actually showed, is that kind of right after the switch of the policy, which is kind of like that vertical line. This is 2001, right when George W. Bush, when his presidency started. You can see that in the countries that were more affected by the policy, their abortion rates started going up. The countries that were less affected by U.S. funding, that didn't depend on U.S. funding as much, their abortion rates kind of sort of meandered on in their own merry way. This was done in 2011, and this article was barely nobody paid much attention to it until. Wait, I paid attention. Of course, some people did. Michelle paid attention to it, but it wasn't. Nobody in Washington paid a lot of attention to it until this is January 23rd, 2017. Okay, what happened 2 days before that?
State of the Union.
Not State of the Union.
Inauguration
of. Yes, and so Trump gets inaugurated, and so what happens? This is switching from a Democratic administration to a Republican administration. He right away puts in place the Mexico City policy, and of course this presidency got a lot of things wrong, and so you know, when this kind of very provocative policy kind of gets put in place, right away people were interested. And so the hours clock and the minutes clock, so the minutes clock and the seconds clock aligned, and all of a sudden our work became very, very relevant. I'll just read the bottom here. I further direct the Secretary of State to take all necessary actions to the extent permitted by law to ensure that U.S. taxpayer dollars do not fund organizations or programs that support or participate in the management of a program or coercive abortion or involuntary sterilization. Right. So that's the crux of this policy. And that was kind of the moment that we got involved in this. Subsequent to that, we actually had sufficient interest that we got a bunch of students who wanted to work on, let's extend this original analysis, and this original analysis sort of held up. It turns out that you can kind of see this up and down of abortions. As soon as the funding gets cut off, you see the abortions rate rise, and as soon as funding for family planning comes back on, you see them abate. So this was the art of health policy. The science of health policy is a lot of grinding, and there's nothing for you to see except that this is my chicken scratch. This is my handwriting. When I teach a course on kind of applied methods for masters and PhD students, and it's a lot of this. That you kind of have to work through and get through the concept of what are the methods, what are the designs, what are how do you kind of imagine a study that would let you really understand what's happening in a messy world. A lot of these methods initially come from the world of economics, in part because economists have been kind of used to trying to take a messy world and really try to understand how things are related. And so this kind of science is there's a lot also for me to learn. Every time that you see one of your professors teaching a new course, it's because they want to learn it themselves. And so there was a part of me that wanted to make sure that I'm up to date and that I'm growing and that I'm developing and that I'm learning more. And so that's what I teach. And so every spring we have a host of PhD and master's students that are taking this course that really are learning how to do this kind of applied research and try to understand how policies really affect what we care about, and that's the health of people and communities and populations. I forget if Michelle mentioned it or not, but once you kind of develop this toolbox, you can really take it to a lot of other areas. And so you really have the set of skills, you develop them, you can really take them to other areas of passion. We've done a lot of work on armed conflict, partly from growing up in Israel, partly because it's always been one of these things that's on my mind. It's kind of under-recognized as a persistent you don't quite recognize how many people actually are affected by armed conflict. You kind of hear about the actual event, if at all, but you don't really get a sense of what's happening in the area, in the region, in the months and years subsequent to an event. And so we actually spent quite a bit of time looking at armed conflict mostly in sub-Saharan Africa, but also in Asia, obviously in Afghanistan and Central Asia. And looked at what happens to child death, and you can kind of see that as the conflict itself gets more intense, you really see a huge spike in child mortality, and our work on that has kind of evolved over time, and somewhere between 3 and 3.5 infants younger than 1 died or had died related to conflict. Much more than the actual number that's recorded. Okay, so the numbers that you see in the newspapers and the data sets, these are just a fraction of the actual number of people that are dead. And this kind of an effect really lasts almost a decade. It takes almost a decade for things to get back to some kind of a baseline. It really sets a place back.
Eran, in that paper, you also correlated distance from the area.
Yeah, exactly. So you can really get a flavor. So that's the other thing is you can see, like when people talk about what can you use this for policy? Well, a lot of it you can use for planning, and so you can really have a sense of how far away from the area of conflict, which areas tend to be more sensitive than others, and which populations. And so in addition to children, women, orphans, these are all populations that are very directly affected. Okay, and I'll just kind of pause here at the end of this and say that the skills marrying the passion can take you to has taken me into areas especially around climate change, and environmental degradation. We only have one planet, and so in order to really get a sense and really understand what is happening, it takes a lot of kind of thoughtful, persistent action. We have some folks here who are working at Woods and know that how dogged this work has to be. COVID and pandemic policies. How do we make sense of the tangle of bad options? And by that I mean you can try to really restrict movement, but when you do that, you kind of you limit people's livelihoods, and right. How do we make sense of what do we get for the different pandemic policies? And I'll just end with a short quote from Viktor Frankl, who wrote *The Man's Search for Meaning*. Forces beyond your control can take away everything you possess except one thing: your freedom to choose how you will respond to the situation. And so with that, I'll say, it's been a real pleasure. It takes a lot of patience, a lot of doggedness, a lot of work with other people. There's been a lot of pleasure and a lot of hard work. But it's a path. You have to enjoy the path along the way for many of you. So I'll pause here. I'm happy to answer questions directly, and if Rhoda wants to come, and I'm happy to have the conversation with you.
Hello everyone, like was stated already, my name is Rhoda Tanomenka. I'm a first year medical student, and based on questions you guys submitted, I'm going to ask Dr. Bendavid a few questions. Thank you, by the way, for such a stimulating conversation. I don't think I'll ever forget, the marriage between skill and passion, and that is something I always try to, carry with me wherever I go. So I think the first question, which I think you've kind of answered by going through your story, was, and this was the question that multiple people kind of submitted in like one form or the other, is what are some tangible and useful skills that you think are beneficial for policy research work, and also how can students and residents get involved in policy research?
Yeah, so that's these are all questions that we both get very often, and they're not always easy, right? So very commonly a question we ask is how do we make sure that this gets translated into something tangible? And I think the answer I give is have patience, and a lot of these things will even if as long as you kind of stick with something that is important, you keep bringing it to light, you keep working at it, that the time will come. And if you kind of provide enough depth to your work, then you become kind of the person that can really make a difference. One of the reasons that appeal to me about policy is that as a relatively small thing, so our work on PEPFAR, that on the abstinence part of PEPFAR, made it essentially helped turn that part of PEPFAR off, right? So that was an ineffective portion of PEPFAR. All of that money is now went on to fund parts that are either prevention or treatment that were much more effective, and so it can really make a difference at scale, and that's kind of a part of the satisfying piece of this. In terms of getting involved, we for students we often have fellowships. I think I would say a lot of it is kind of throwing yourself in there. I've had a couple of PhD students who are in neuroscience or in immunology just come and say, look, I'm in my PhD, but I want to spend some time with, doing some policy research, and I would, either take the course or spend a rotation, spend a few months doing a project. And so that's kind of like an initial foray into the work. It's not easy, and so the kind of sometimes the sense of, can I just come and do a short project, that tends to be maybe just a flavor, just a taste, not much more. But for people who I think the kind of the commitment and the sense that this is really where I want to spend my efforts is important.
Thank you for that. Yeah, I hope as we leave this place, we'll all remember to put ourselves out there in all our endeavors in global health policy or whatever else we're working on. The next question is, what has your research uncovered about the impact of foreign aid on health in a country?
Yeah, there's almost a sense in which I feel like I know too much, and so sometimes the challenge becomes kind of distilling some of the lessons. One of the things I would say is that foreign aid is, depending on what it's given for, it hasn't always been used for the intended purpose. And so for some areas like infrastructure or construction, sometimes actually a lot of that money really has it's hard to really see the tangible impacts. Health has actually been one of those areas where a lot of the money has actually, you can really see the impacts, right? And some of it, as I think, is because malaria, you can really make a big difference pretty easily, right? It's like, you blanket an area with artemisinin-containing medications, and you can really make a huge difference, or insecticide-treated nets. So, foreign aid for health has been one of those areas where I feel like there has been a huge difference. I think that the challenge for foreign aid for health is to find the areas that are good priorities. And by that I mean areas where either there's not enough, there's high burden that you can address with whatever aid can accomplish, which is not everything. So you can't substitute the country's own Ministry of Health. So you somehow have to find your way, and make it in such a way that and find those priorities that the government itself doesn't wants you to come and support. And so finding those areas and those partnerships is kind of the challenge for foreign.
Thank you. Also, one of the questions is it possible for you to tell us about the main challenges in translating research into policy, and more importantly, translating policies into law?
So it's one of these things where I should start a course because I want to learn more about that. But I would say we have I spend most of my days over in right next to the Freeman Spogli Institute, and that's where you have a lot of folks who've actually spent time in government and have come back and forth between the academic and government, and are really interested in that question. And I think even they have a lot of challenges, and just trying to figure out how to make that link between the academic and the world and the policy world. And I think there's this this some of it also again kind of takes like just making the connections, coming closer to policymakers, having those discussions, trying to understand what would help them. I have a former trainee who spent some time with WHO doing guidelines on deworming, and at the end of that he said, I'm gonna leave here with you a sheet where I want you to guys, whenever you have a question, just put it down on that question, and I will take it to my network of colleagues and researchers and friends, and we'll try to do the research that's going to help you answer that question. And I think that was a great idea, right? Where you really bring the researchers and the policymakers closer to one another. I think that's it's kind of it's a process. It takes time, and there's no formula to it. I think, unfortunately, But I think, I think that it's something that kind of, you sort of, it's definitely, you can definitely become more effective at it over time. There's that model of academics actually spending time in government. I think is interesting, right? I would love to spend some time actually doing some government service, in part because I bet there's stuff that's going to be fascinating about how the government works that I just don't understand. And from here it just kind of looks like, there's something that's going on there. Anyways, but really getting into the nitty gritty of the everyday work of setting policy and deciding on policy and deciding on strategies. I think that would be something that would be very useful for a lot of folks in universities. On turning it into law, I don't know.
Yeah. Just like based on what you said, I think one thing that comes to mind for me personally is like in medicine, they've started these strategies of like MD, PhD programs for physician scientists to kind of try to bridge the gap between research and actually meeting the medical needs. Are there programs like that for maybe like health policy and law, and if they don't exist, do you think there's a need for programs like that?
I would say that when we bring our students, our trainees into a PhD program in health policy, a lot of what we actually train them is really to get to the point of understanding. And I think the understanding is actually, I think that's the first stage, right? You have to really get a deep understanding of an issue, and you have to kind of go through the process of asking the questions, trying to see what you can sort of really sort of bring out, and so I think that that's the first question, and so that's the first step is really getting to the point of understanding, but we don't do a very good job at actually having them sending them to the actual policy setting pieces, and I think that's something that we can definitely work on and improve. I think the model of translational medicine, where you kind of go back and forth between the bedside and the bench, I think is a good one, and it'd be interesting to have our PhD students actually spend time in state government or state Department of Health.
Thank you. I'm gonna ask 2 more questions, and I promise I know you guys are dying to ask me your own questions. I'm gonna take it to the floor. So the second last question is, what do you believe is the greatest challenge in health improvement in developing countries?
Yeah. No. What's that? That's right, exactly. The thing that comes to mind first and foremost is the overlap of poor health and poverty, and I think we kind of that aspect is hard to ignore. I think despite a lot of years of trying to understand how we can even improve health even in places that are poor for a lot of structural reasons, and really are struggling to really grow out of poverty. You can make some headway in health, but I think getting people clean water to their homes and really getting to conditions where you can protect your baby from overheating and from things being too hot or too cold. I think those are kind of fundamental things that just a little bit of getting people out of poverty will make a huge difference. So I remain there. I think there's questions about the things that are in my mind about sort of climate change and environmental change. I think all these, to me, when I spend time in I have projects that I haven't been there in a while, but projects in Zambia and in Kenya. Just my first instinct is just it would be so nice to just lift people a little bit out of the conditions in which they live.
Last question. Countries that contribute the least to climate change often, usually unfairly, bear most of the consequences of climate change. So what do you think are some policies that can be put in place to help mitigate this injustice?
Yeah, we just did a paper that looks at kind of the big emitters of pollution, where do they, the pollution, where are the health impacts felt? And you do see something that's kind of wild. It's where when the U.S. emits or when the European countries emit, they don't experience the health impacts of those emissions, in part because actually, by and large, the health status of most people, especially our children, is high enough that they're just not as sensitive to that. But when you see India, and when the U.S. emits, the Indian kids do do suffer from that. I think a lot of the policies really have to, at this point, a lot of the focus of climate control and regulation, I think you should focus on the wealthier countries. I think the emissions, and obviously in a lot of these countries, and a lot of the degradation of the environment is long term is crucially important. But when the kind of the trade-off, I think, between kind of allowing people to sort of get their sort of foot in the bottom rung of the ladder of getting out of poverty, I think it's a hard trade-off.
Thank you so much for such insightful perspectives and such stimulating answers. Would you all join me in giving Dr. Bendavid? Yeah.
Have a seat here.
Oh, thanks. Now up to you. Thank you.
Thank you very much. Really very interesting perspectives. Two questions. One is, what are you the most proud of what you have done professionally so far? I'm sure you get this question quite often, so you probably have an answer quite ready. The second is, there's this other pandemic that is less often talked about, the infections that are multi-resistant to antibiotics, and I'm not just talking about TB, but pretty much all the others. What do you think is done or should be done about it?
Yeah, I can answer the stuff about the what I'm proud of. I think that the work we've done on foreign aid has been very influential. I see it all the time now. People really have taken it to heart that in many ways foreign aid for health is a great way to spend your kind of tax dollars on there's time and time again this priority gets kind of stated out loud and gets enacted in foreign aid decisions, and so that work has both been kind of personally satisfying and has had an impact, and so that's been quite nice. On antibiotic resistance or any kind of antimicrobial resistance infections. Again, it's almost like I think of that as we use antibiotics for a host of reasons, and a classic are a lot of infections like chlamydia that we had a pretty simple regimen, and now because that regimen became very widespread because a lot of people needed to be treated, there's no resistance to the antibiotics, and there's obviously it gets also entangled with a lot of antibiotics used in livestock and in farming, my hope is that actually there's going to be enough of I almost think like there should be like a cat and mouse kind of issue with that. Is that you see there's new development of new drugs for multi-drug resistant TB, and so there'll be a continuous kind of development so that we can continue to treat the people that have the resistant infections, that will have options for those. And so because it's hard for me to see how we can avoid getting resistance when we want to use the antibiotics. And so that I think that to me is part of the challenge.
If I could add on onto that, a lot of the, also, first of all, thank you so much for coming to talk to us.
Yeah.
A lot of like the golden age of antibiotics research has really like ended because it's so expensive to
Yeah.
fund new therapeutics. How do we incentivize this research in developing new antibiotics?
No, that's exact. I mean, I should have added that, right? Because my hope is that there would be continuous development of antibiotics, but I think it's also, I think you're exactly right that you know, it's not this, it doesn't have the same kind of golden age. It's not as lucrative as it used to be, and you don't see pharmaceutical industries investing in developing new antibiotics as much as they used to. And you know, how do you incentivize? You know, my hope is that there's you know, there's going to be some technology, some scientific development where these kinds of antibiotic developments can be actually made a lot easier, right? So you know, you can see where the new resistance mutation is or whatnot, and you can figure out what the molecule would need to be that would develop it. And so that's my hope. I think that you know, that there are places where I have some kind of scientific or you know, technological optimism, and I think that's actually one of them.
There's a question.
Yeah.
Professor Bendavid, thank you for that
Yeah, of
fantastic
course.
talk. Coming as the global ophthalmology fellow, so I'll give you two questions. One, you presented a fantastic chart about disability-adjusted life years, and you mentioned about prioritization of medical issues or issues in large and policymaking. What other metrics or anecdotal or anthropological evidence do you use when you're trying to sort through what priorities and what diseases to address? The other topic that maybe you could share some insight on, in global ophthalmology, we talk a lot about sustainability of interventions. There's a great model for doing these high volume cataract surgeries in some lower resource countries. But one contentious point is that it could be harming the local economy for the local ophthalmologists. That's something that I'm trying to grapple with currently. If you have any thoughts on those two topics.
Yeah. No, so you know, on prioritization, you know, I think the burden, you know, getting a handle on the burden, I think is kind of step one. The other important piece is what kind of interventions are available, right? And so, you know, I mean, I think, you know, colon cancer is actually kind of a pretty high burden condition, but getting operating theaters to all the places that need it is a pretty tall order, right? And I would love to, and I think it's, you know, it would be important, but you know, it's really hard to, you know, there will be a very expensive set of kind of public health interventions. You know, on the other hand, you know, again, you know, something like a bed net is pennies, right? And so, you know, almost like the, you know, I'm using it colloquially, but the cost effectiveness of what are the available interventions is actually a very important priority, right? So that I think, you know, not just what's the burden, but you know, it's almost like how many life years or how many dollars can you avert with the available resources, and that's a view that takes a little bit of you know, there are scarce resources. There's not, you know, and I think, you know, you know, I think that you know, at least in the foreign aid, in the global, in the kind of the international relations on the foreign aid, on the global health aspect, I think is something that we can't avoid, because there is only so much money that the U.S. is going to spend on global health. And so thinking about those issues of how much can you get for that limited amount of money is important. And remind me your second question. I'm blanking on it now.
The effect of foreign intervention and aid on the local economies that we're interfacing with.
Yeah. You know, probably over the last 10, 15 years, I've seen a process where, you know, so for example, you know, South Africa, when I started working, they were, you know, they were allowing PEPFAR to really run a lot of their HIV program, and PEPFAR was developing their labs and helping with a lot of the medication programs. And at some point, or you know, over time, and I think appropriately, you know, the balance shifted entirely, so that now it's pretty much entirely the government. You know, there's very, very little foreign that's still in South Africa that's doing HIV, and I think that's appropriate, right? I mean, I think that, you know, you know, it's both let's the government have more agency, and the kind of resources are more sustainable. You don't have to worry about the fickleness of whatever presidential administration happens to be in the U.S. And so I think those, and so that there's I think Michelle was for a while involved in a big program to try to increase capacity for medical care and for medical schools and resources, and I think was it just in sub-Saharan Africa, or was it?
It's sub-Saharan.
Yeah. I think it's for long term that has to be part of the solution, is kind of developing the capacity for people to have
I
this.
think if you're a global ophthalmologist, you're very aware of what maybe other people aren't aware of. But I think it's bigger bang for the buck is to bring capacity, teach those folks to be ophthalmologists.
Yeah, and we had people from here
Right.
teaching Zimbabwe, right, and so that was they developed a whole curriculum that I think was very to me that's an important step.
Yes, thank you
Yeah,
for
yeah,
the really
yeah.
interesting talk.
Yeah.
So, I want to ask a question about the type of questions we have, and we're hoping to do more now. And I'm more thinking directly related to the environment and climate, which is the field I'm coming from, but I'm sure this also applies to other topics. So when we look at the research we're doing right now, there are basically kind of two types. One is quantifying the impacts, and we see a lot of this kind of research, and this is also my research, and we often joking about like, our research is always environmental problem X is worse than what you think. But then there seems to be also the more important type of question is how do we address these environmental challenges? So I was wondering about your perspectives on how can we better connect those two things, or maybe how we better facilitate the production of the second thing, which is potentially more important, but we don't see much often in the field right now.
Yeah, the view from the medical field is that once you kind of have a sense of understanding of how things are related to one another, you try something, you do a trial, and that I actually think there's probably room for a lot more experimentation, and some of it is, I think, important because for a lot of things we can understand the relationship between A and B, but we don't know what would happen once we tweak A. I think there's kind of a lot of models for that work, and I think try to imagine you work on wildfires, try to imagine some kind of a wildfire mitigation program, right? And you can try a couple of different things and look at the health impact. It doesn't have to be the same kind of big randomized trials, obviously, that we have in medicine, but I think having more of that model of, here's an important problem, and that's where I think the other role for getting to a good place of understanding is if you bring out a study after study after study showing the adverse effects of wildfires, California is going to take notice. Someone over there and they're Cal Fire and all these places, they're gonna take notice, and then they're gonna be like, okay, well, here's something. Here are the places that we think are gonna be most affected. Here are the populations that are gonna be most affected. Let's try to do home air PM 2.5 monitoring, right? So something along these lines. And so this kind of experimentation, I think, is important. That this, again, I think that the point of getting to a good solid state of understanding is a lot of what we can bring to the table, because once we kind of have almost like a weight of an issue, then we can then it's easier to kind of see how we can move forward with it.
So, Eran, let me follow up on that.
Yeah.
Because there is great work that's done at Stanford. Your work is great. There are a lot of people in this room that do great work. But often it languishes in scientific journals. And the fact that you have to do it over and over and over again before someone takes notice. Do you think there's a better way, and I know Allison, we've given some thought about this, of getting that work into the hands of influencers or government or policymakers earlier? Because the brownie points in academics is not to change governance or policy. The brownie points is to get those papers out.
I know. And I think that's unfortunate, right? Because the real meaning is in making the world a better place. And so and this is where again I keep thinking about that process of getting closer to the policymaking process, and
So we're actually trying to think of doing a climate fellowship. We have our postdoctoral fellows in climate and health, but what if we took medical doctors and actually put them into the EPA or NOAA for a year? We actually have a concept paper. I can't find anyone to actually fund this, but I think that is one way. And you don't have to be an internist, or you could be a pediatrician, surgeon.
Yeah.
Just get an understanding of how government works.
Yeah,
Particularly
there's-
on climate, which is.
the California has the Clean Air Board, right? Have somebody almost like an intern or a fellow at the Clean Air Board.
So if you find a donor, please let me know.
Yeah.
We tried Bezos already.
Yeah. Okay.
We have to get back.
Have you received any pushback from your papers about interventions in Africa not working? Because obviously the U.S. committed all these billions of dollars to putting in an intervention, and sometimes obviously things don't pan out the way you hope and stuff.
Yeah.
Was there ever anyone in policy positions who tried to refute what you said, and I guess how did you address that?
You should have seen how mean this guy was. He wasn't. And over the years, I've gotten to know him, and I appreciated where he was coming from. But yeah, the answer is yes. And I think every time that you kind of try to do something that is, is going to nudge people kind of in places that are uncomfortable, you're going to get pushback. So we got a lot of pushback on that. We got a lot of pushback on the Mexico City policy. So this kind of work, there's always going to be, especially in kind of increasingly polarized, increasingly politicized environment, there's always going to be people who are going to be, and I think this is where, there's, I sometimes think about the attitude of the scientist, and it's something I don't have this fully clear in my head, but there's places where I think it's important to have people that stay the scientists and actually really have a clear boundary between what they do and being the advocate. And that's hard because sometimes you want to be an advocate, but I think staying the scientist kind of gives you both the perseverance, the motivation, and the credibility out there to be like, okay, here's this guy's, he keeps kind of putting on the numbers, crunching the numbers. Here's another study that shows, and I think that's an important aspect. I don't think universities should be isolationist in that way, but I think there's it's an important balance to try to negotiate.
Question about the data that is used to do this diagnosis of interventions. Do you see some areas where the data is lacking in a strong way?
Huge.
And if you were to dream, or which kind of data could you get? And do you have some ideas of new tools coming up or new tools that would be helpful?
Yeah, boy, where do I begin? There's the global burden of disease. I greatly appreciate what they've been doing, but they estimate, when they try to estimate, for example, what's the malaria burden in Chad. They will rely on a handful of small studies. Maybe somebody will try to kind of get a sense of how many bed nets are out there, and so it's very sparse, and so for a lot of things you really are relying on things that are very sparse. We have been actually for quite some time now, and again trying to write grants and get NIH to kind of support that, trying to get a whole different approach of doing that's going to rely on either remote sensing or a lot of kind of constant monitoring of people through other mobile devices or something that is easy to connect with them. I think that there's a lot of potential there. It's also very hard. You can imagine that it's hard to kind of get a flavor of health status from satellite pictures. I think it's you can get close, and I think it's going to be a whole different approach to understanding burden. We'll have it constantly, like a high frequency everywhere. You don't have to, the global burden of disease just kind of assumes that whatever is happening in Khartoum is happening in all other parts of Sudan. So those kinds of things are I'm hoping that will get better, but the data is sparse. We're constantly kind of, whenever we're identifying, we're finding a new data source or a new survey or a new someone is, we were with Michelle in Ethiopia with this meeting of this network of household surveys. Man, that was really exciting, because all of a sudden you have this, it's like a little set of household surveys that are being done in all these different places, and there was an attempt to really bring them all together. It fell apart, which is kind of unfortunate, but it's really hard.
I think one last question.
Yes.
Because we should end at 7.
Oh,
Go
I was
for it.
gonna ask, was that the DHS?
It wasn't DHS. DHS has actually been my kind of, I love DHS. I should have like a sticker. But it was the household surveillance surveys, IHSS, and it was in this network called the In-Depth Network.
In-Depth.
Yeah, which kind of fell apart. So you still have all the individual little household surveys like in different places, but there's no way to kind of bring them together, which is what you need when you want to have generalized knowledge.
Yeah, I'll check it out.
Yeah.
Anyway, Eran, thank you, and Rhoda, thank you
Thank
very
you, Rhoda.
much, and thank you
Of course.
OGH for
Yeah.
pulling this together. And thank you, Yousefa, for organizing the food and the evening.
Thank you everyone for coming and write me, call me, I'm around.
Thank you.